binding types. There's so many different types of things that we can see in the breast on MRI. And I will be going over a few of these. Okay, so a focus is essentially an enhancing dot that's less than 5 millimeters, and it's too small essentially to characterize. So we dismiss foci, particularly if they are multiple and separated by normal tissue. And if they're uniform and T2 hyperintense, they're overwhelmingly benign, and so um, we also just dismiss it in that case. All right. So, how do you make sense of foci? Again, a difficult part of breast MRI is how do we make sense of these? So, it's foci are more likely to be benign if they demonstrate hyperintense signal on T2 imaging. If obviously it has a fatty hilum, then that can lead us down the route of, is this an intramammary lymph node? Persistent kinetics. It's been stable since the prior exam. Priors are breast imager's best friend, or a radiologist's best friend for that matter. It's more likely to be suspicious, though, if it's hypo-intense on T2 imaging. You don't see a fatty hilum. Of course, washout kinetics, but again, with the caveat of if it's a lymph node, be careful to not fall into that trap. Or, if it's increased in size since the prior exam or new since the prior, that's important for you to pick up on. And if a focus has an irregular shape, margin that's not circumscribed, or internal enhancement characteristics, then it should be described as a mass. So if you can actually describe things about the focus, then you need to describe it as a mass. Okay, so mass is a 3D space occupying lesion. And we look at different characteristics of the mass, as you know: shape, margin, internal enhancement, and kinetics. All right, so as far as shape goes, we report if it's round, if it's oval, which is up to 3 gentle lobulations, you can call a mass on MRI oval. And if it's irregular, then meaning that the shape has sort of uneven edges, then we call that irregular. So round, oval, and irregular is what we report on the MRI. That is in keeping with the latest version of BI-RADS in the terminology. The margin is an important predictor of malignancy. Is it circumscribed? If it's not circumscribed, is it irregular? Is it spiculated? Now, remember, out of all the modalities for breast imaging and BI-RADS, mammo, ultrasound, MRI, on MRI, that's the only one where you can report that a mass is irregularly irregular. Okay, so you can call the shape and the margin both irregular. You cannot do that in ultrasound, and you can't do that in mammography. Again, I would stress for you to know BI-RADS like the back of your hand. If you are a budding breast imager, it will serve you well. So again, only modality that you can call a mass irregularly irregular. And again, morphology trumps kinetics. I said it earlier. Super important to really look at the morphology and follow your gut with that over the kinetic pattern. Okay, so mass characteristics, we look at the internal enhancement pattern. Is it homogeneous, or is it heterogeneous and just non-uniform? Is there peripheral rim enhancement? Or are there dark internal septations? We know that dark internal septations in a mass is suggestive of a benign fibroadenoma. So these are things that can really help us in characterizing and figuring out what the mass actually is. Okay. So this is just an example that shows you the green arrow is pointing to a mass where it's over 5 millimeters. Here we have a round circumscribed enhancing mass. And this is a focus where it's less than 5 millimeters here. So to show you sort of the differences between a focus and a mass. I just threw in this slide or case here, essentially showing you these are maximum intensity projection images that this patient in 2016, she had been. This was prior to chemo to receiving neoadjuvant chemotherapy. There's obviously a very large malignancy here in her left breast, and then she received neo, and then she had a follow-up MRI to assess the area, to assess response to treatment, which had significantly reduced in size. So again, another example of why we use breast MRI to assess response to neoadjuvant chemotherapy can be very, very useful. This is another example of a malignancy. These are subtraction images, and you can see this irregular enhancing mass. And so this was another example of a malignancy. Of course, you would need more sequences to really determine whether this was a cancer versus something like fat necrosis, where fat necrosis, obviously, you're going to see areas of T1 hyperintensity on your T1 images. So it's important to look at the T1 to delineate, fat necrosis versus malignancy, particularly in those patients who've had a history of cancer and surgery, and you're trying to figure out what is what. Okay, so, invasive malignancy on MRI. MRI is really useful to determine extent of disease, cancer in the contralateral breast, as we chatted about, response to neo, occult breast cancer in a patient with axillary metastasis with negative mammo and ultrasound. For all modalities, of course, and most common for MRI, we see invasive ductal carcinoma. Particularly, the classic appearance is an irregular enhancing mass with or without rim enhancement, and with a washout kinetic curve. When we see this, the probability of malignancy approaches 100%. And this is just, again, showing you that previous slide that I showed you about the malignancy, to use these images, these different sequences, to aid into what you're seeing. So here on these subtraction images, we see this enhancing mass. And obviously we see areas that are dropping out here. So we need to really figure out, is that fat? What is that related to? So if you look, this is a T1 non-fat suppressed image, and I don't really see any areas of T1 hyperintensity. So to me, this looks more like a malignancy than fat necrosis. So again, your sequences can really help you to problem solve, to figure out what something really is, especially if a patient has had a prior surgical history and known biopsy proven malignancy. Okay. So, I'll briefly talk about fibroadenomas. This is one of the benign lesions that we can see in the breast that demonstrates that persistent type 1 kinetic pattern. And, remember, though, that as these fibroadenomas age and as estrogen levels go down, these fibroadenomas tend to die and calcify. Fibroadenomas live off of estrogen. They drink the estrogen. And once those estrogen levels start to plummet, they die and they calcify. So then if they calcify, degenerating fibroadenomas or involuting fibroadenomas may not enhance. And so that would make sense, because they are largely replaced by calcifications, which don't tend to enhance. So that is important to know as well. So this is an example of a fibroadenoma. You've got an enhancing mass here, and then you have, it's hard to see, but there's non-enhancing internal septations. There's one right there on this MRI in the right breast. And then here you can see that there are, the kinetic pattern is demonstrating a persistent kinetic pattern. So all signs leading to a fibroadenoma. So that patient ended up having a second look ultrasound. I think that with this case, it wasn't 100% certain that this was a fibroadenoma. As I showed you on the subsequent slide, there was a non-enhancing internal septation, but didn't look like it was totally diffuse. So in those cases, sometimes it's hard to tell, right? So this patient went to ultrasound, at a second look ultrasound. And again, here you see this round, predominantly circumscribed hypoechoic mass. There is internal vascularity, which you can see in the setting of a fibroadenoma. And actually, this patient ended up having it biopsied, which can most certainly happen if, at the discretion of the radiologist, if they're not 100% sure, if the patient's young, maybe they're high risk. There's so many clinical scenarios, but essentially this was biopsied and came back fibroadenoma. Okay, so non-mass enhancement, it's not a focus or a mass. It's discrete from normal breast parenchyma. It may encompass small or large areas of the breast, and it tends to be interspersed between fat and normal fibroglandular tissue. So for NME characteristics, we look at the distribution, the internal enhancement, and the kinetic pattern. So the distribution is important, and we have different categories like I previously demonstrated: linear, segmental, focal area, where we have a small area, about 25% of a quadrant; regional, which is a large area not conforming to ductal distribution; multiple regions, which is greater than or equal to two regional areas; or diffuse, where the distribution of the enemy is throughout the breast. Now, we know that segmental enhancement, where you have a triangle or wedge shaped enhancement pattern with the apex pointing toward the nipple, is very suspicious, particularly for ductal carcinoma in situ. We know that linear can also be suspicious as well. So, from these distribution patterns, we really take linear and segmental non-mass enhancement seriously, because it can be associated and has a high association, for that matter, with DCIS and malignancies, invasive malignancies. Okay, so internal enhancement patterns, we also look at that. Is it homogeneous or heterogeneous, or it's separated by parenchyma of the breast and fat? Is it clumped non-mass enhancement, where it has a cobblestone or grape-like appearance, which is suspicious? A clustered ring appearance, where you have thin rings around ducts, that's also suspicious. So if you see, particularly clumped NME, clustered ring NME in a segmental pattern, you've just got to be thinking DCIS, 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 malignancy. These are very suspicious patterns. So this is an example of a mammographically occult invasive lobular carcinoma. Those of you who are in breast imaging know ILCs are very ominous. They're very scary malignancies, and a lot of times you can have mammographically occult invasive lobulars. So in this case, MRI can be very helpful. Yes, it is known that ILC at times will not show up on MRI, which can be difficult, just like if you have a low grade DCIS. But in a lot of cases, ILC can be found on MRI, which is very, very helpful. So this is an example of a mammographically occult invasive lobular carcinoma in a patient with implants. So you can see that here, you can see sort of where her implants are, and you can see this area of linear NME that's along the implant here that was consistent with invasive lobular cancer. So this is a really great example of this wedge non-mass enhancement, where the apex is pointing toward the nipple. That's what I'm talking about, that segmental non-mass enhancement, the apex pointing or radiating toward the nipple. That is a classic example there. This is an example of clustered ring, where you have these enhancing rings, which has a high positive predictive value for DCIS. So we've talked quite a bit about DCIS and MRI, but just to reinforce the information, although MRI is extremely sensitive to detect malignancy, it's slightly diminished for DCIS, particularly the earlier grade DCIS ones. However, on MRI, we can see many patterns, as I kind of showed you in previous images, or previous slides rather. You can have non-mass enhancement, where you have clumped enhancement, and a linear or segmental distribution. Variable kinetic curves are reported for this. So it can, this is another entity where your kinetic curve, you just can't hang your hat on it. You really need to look at the enhancement pattern, look at the distribution pattern, the morphology. So MRI may depict the true extent of non-calcified DCIS. That's important to know. We see non-calcified DCIS in about 10% of cases, and so MRI can be useful in this arena to determine the true extent. So, you know, we usually recommend now, particularly, I say that we can consider MRI in a patient with newly diagnosed DCIS if she's young, has dense breasts, these criteria. However, I think that regardless, women who are premenopausal now, we are, whether, they have dense breasts or not, we are pushing in the field of breast imaging for them to receive an MRI to determine extent of disease. Um, so although these are factual statements, I think in general, whether they have DCIS, invasive ductal, I think that if you're younger, premenopausal, definitely we are pushing for that. But if you're even postmenopausal with heterogeneously or extremely dense breast tissue, we are also pushing for that as well for these patients to receive MRI for extent of disease. Um, Again, correlation with the mammogram is important. Having that mammogram to be able to refer to while you're looking at an MRI is so important, and it can help you for biopsy planning. What is your plan of attack? And it can help you also with local needle localization planning. Um, you know, uh, if you have, let's say, calcifications on a mammogram and they end up being a biopsy and they're positive and you're not really seeing much on an MRI, obviously the way you're going to want to localize those calcs is under mammography guidance, maybe a bracketed localization to bracket the calcs. So the mammogram with in concert with MRI, it can really help you sort of flesh out what you need to do in terms of next steps for patient care. And then of course, there are non-enhancing lesions on MRI. We've talked about the simple cysts. And then as far as commenting on cysts in the breast, it really varies per institution. We typically don't comment on simple cysts in the breast, but again, some institutions will and some won't. There's just a lot of variability. These are just some examples of some simple cysts here, particularly in the right breast, and there's a couple here in the left. All right, so fat containing lesions on MRI, the T1 pre non fat sat can be useful. And the T1 post fat sat can also be useful because, again, it can help to delineate particularly fat necrosis from malignancy. They tend to be, T1 hyperintense, of course, T2 hypointense. They usually don't enhance, except, the intramammary lymph node that can demonstrate washout kinetics. But other examples include we talked about the lymph nodes and fat necrosis, hamartomas, a seroma slash hematoma with fat and fluid. Those can be other fat containing lesions you see on MRI. This is just an example of a benign intramammary lymph node here in the left breast. It's T2 hyperintense, it's enhancing, it's demonstrating a bit of a, it's a mixed kinetic pattern, but you do see some washout kinetics there. And this is an example of a seroma slash hematoma. These subtraction images don't demonstrate an enhancement, so that's a good thing. We know that there isn't any residual disease. Particularly, it's fluid filled as denoted on this T2 sequence. And here you can see particularly a fat fluid layer that you can see in the setting of a fat containing lesion. These are some other things to keep in mind. And for the interest of time, I, will not go into huge depth of these, but these are things that you want to think of whenever you're looking at lack of enhancement, non-mass enhancement, benign features, malignant features, and T2 characteristics. So important things to keep in mind. So I quickly wanted to talk about breast MRI implants, and essentially, I still have the WashU protocol on my slide deck, which is where I did my breast imaging fellowship, and proud to be a former MIR fellow. But particularly, the protocol can vary per institution. But we typically did, a T2 axial, a T2 sagittal, T2 sagittal silicone only, and then a T2 sagittal silicone saturation, which is super important to help delineate water from silicone. So that's an important sequence that you need. Okay, so these are the examples that I mentioned that can really help in aiding in the to look at implant integrity. And again, the T2 silicone sagittal silicone saturation sequence can really help us delineate if there's just some water around the implant versus some sort of rupture. So there are so many types of implants. I would say a lot of this information is important, particularly for the plastic surgeons. But I did just throw it in there so that you have that information of all the different implant types that you can see. I think these days we're typically seeing more of the single lumen, particularly silicone. We see that a lot, of course, saline. A lot of these different. Double lumens. We don't see as much. However, this will vary per practice or institution, depending on the plastic surgeons, kind of what they particularly like. But again, lots of different implant types. Okay. So the FDA actually recommends assessing silicone implant integrity with non-contrast MR every 3 years after the implants are placed and every 2 years thereafter. But not a lot of people do that actually in the field, unfortunately. And it could be that they're just not aware of this. Obviously, insurance coverage, and will patients have to pay out of pocket for this? So there's a lot of different variables to that. But and then we talked about, for evaluation of saline implants, mammography and clinical exam is the gold standard. So the implant rupture types. So we know the most common silicone implant rupture is an intracapsular rupture, which comprises 85% of cases. This is where the rupture is confined to the fibrous capsule, and the fibrous capsule stays intact. And we see this in the form of Linguini sign on the MRI, also known as the stepladder sign on ultrasound, where you see these wavy lines. We also see other forms of intracapsular rupture between the fibrous capsule and the disrupted envelope or shell, keyhole sign, noose sign, and teardrop sign. And these signs are named these things because they look like these things on the MRI. And then extracapsular comprises about 15% of implant rupture, where you have extravasation of the implant of this silicone outside of the fibrous capsule. And the capsule is not intact, of course. And this is where you really start to see the change in the implant contour. Remember, you cannot have an extracapsular rupture without an intracapsular rupture. That's something really important to remember and makes sense, right? You've got to have that intracapsular first, that rupture, before you reach that extracapsular stage. This can also be seen in the form of silicone lymphadenopathy or granuloma, and that snowstorm appearance on ultrasound is synonymous with this. Okay, something important to note is that a small amount of water around the capsule, as well as in the folds, is normal. But a large amount may indicate an infection or even something such as an implant associated lymphoma. So that's important to know. But again, a little bit of water is okay. This is just an example of a Linguini sign on MRI where you see these wavy lines indicative of your intracapsular rupture. And then here it is on ultrasound where you have the stepladder sign, where you have these wavy lines and you have this disruption here of the anterior aspect of the implant. You can see that there is a disruption, frank disruption. And of course, you can see these wavy lines indicative of rupture.